who is going to take us through the gastrointestinal symptoms, second session today. Over to you, Dr. Rutula.
Hi, hello everyone. I'll just start sharing my screen. Can you see my screen?
Yes, Rutula. Yes, go ahead.
Today we'll be covering two major topics, which is constipation and malignant bowel obstruction. So, in general, what is constipation? Constipation is basically infrequent passage of stool. Now, it is persistent, it is difficult, and incomplete in nature. So it might so be that they are passing stools every day, but it is not complete. So that is also categorized as constipation, right? So you have to ask them the history, whether it is their normal cycle. Like for some people, it is normal to pass stools every other day. So you have to ask them what their previous normal was, and it has this, or is this differing from their daily routine, right? So anyone can tell me what are the normal functions of a colon? Any normal colon? What happens in the colon?
Absorption of essential nutrients and
And
removing the excreta outside.
okay, water absorption is major. So electrolytes and water, that is the main thing that happens here. So okay, so coming to the anatomy, basic anatomy. So we have the mucosa, the submucosa, and we have the plexus and the circular and muscles, right? And the serosa after that. So here what happens is, if you look at the complete intestinal tract, supposing we are taking around 2 liters of fluids orally, and then we have all the secretions and everything, which adds up to around 7 liters. Okay, like secretions, plus you have 2 liters of fluids intake. So that is total 9 liters of fluid which is going inside, out of which small intestine absorbs around 7 liters, colon around 1.9. So total 8.9 gets absorbed, 1.1 is excreted out of the gut. So this is the normal fluid balance in the gut. Then coming to the pathophysiology, basically what happens is that it can be due to multiple reasons, right? It can be because there is less water intake, if there is less fiber in the diet, like bulk forming substances are reduced. If there is any psychogenic disorders, if there is any surgery being done or trauma which causes paralytic ileus, if there is mechanical obstruction, if there is any neurogenic or myogenic disorders, or drugs which can cause constipation. Now, in our setup, it would mostly be drugs which are causing constipation, especially opioids. So we'll have to manage that accordingly. So what opioids does is, how does it cause constipation? What is the mechanism of action there? Anyone? What do the mu receptors do? Inhibition of motility. So basically, it slows down the gut. So if you want to counteract that part of it, what you'll have to do is give something that increases the motility. So the laxative of choice also would depend on why there is constipation, right? Okay. So coming to other causes, basically even endocrine or metabolic disorders can cause constipation, like diabetes or thyroid disorders. Neurological disorders also can be there. Any anorectal issues like fissures or strictures or IBD, they are also prone for having constipation. Psychogenic disorders, iatrogenic or dietary lifestyle. Then non-pharmacological measures would be giving high fiber diet, which increases the bulk, so peristalsis increases automatically. You have a good physical activity, which again helps you mobilize your gut and have a very good regime for gut output. Then fluid intake, and you ritualize your bowel habits. So make it a compulsory thing. You go on a particular time every day, and slowly over time it gets into a habit. Pharmacological treatment. So as I said, it can be bulk forming laxatives, it can be surfactant, which are also called as softeners, it can be osmotic, which increases the fluid in the gut lumen, it can be stimulant, which increases the peristaltic movements, or Camoras, which are particularly for opioid-induced constipation, which is basically what is peripheral antagonist. So it has effect on the peripheral mu agonist receptors, which inhibits those, so has this antagonist effect, and that effect goes away. So the constipating effect of opioids will go away with Camoras. Unfortunately, it's not available in India. So we'll have to make do with other laxatives. Now, constipating agents, anti-constipating agents. So basically, bulk forming would be your, what it does is basically it bulks up the stools. So what happens because of that is that your bowel gets distended and peristalsis occurs. Softeners help in smooth passage of stools. So basically, it avoids any pain or fissure formation if it's been too long since he or she has had any bowel movements. Lubricants or emollients, again, they soften the stools and make it soft. So and prevent further absorption of water in the fecal matter. And hydrating agent again increases the water content in the stool, so makes it bulky and soft. Stimulants, which increases the peristaltic movements of the intestine. And others can be prokinetics or prostaglandin analogs. Then basically these are the sites of where these agents act particularly. So if you give castor oil or polyethylene glycol, they act more in the small bowel, colon. It's basically your senna derivatives and bisacodyl or lactulose. So as I said previously, lubricants basically eases the passage of stools. It minimizes the pain, and lubricant examples would be docusades, oil enemas, or glycerin suppositories. So if there's a hard impacted stool, it's always good to give glycerin suppository so that it softens up the stool, and then give enema so that it passes very easily. Otherwise, what happens is if it's a very hard impacted stools and you give enema, there's a high chance that the patient might develop anal fissures, which can be very painful. So motility agents. So if there is decreased more activity, these agents would be preferred. So these are senna, bisacodyl, or enemas. Again, why it happens is because of so senna and bisacodyl will act on the your plexus, but enemas basically dilate your gut, so and thus increase your peristaltic movement. So what are the various medications which cause constipation? So these are the examples. So analgesics, as we said, your opioids cause constipation, highly constipating. Anticholinergics would cause constipation again. Your calcium channel blockers, diuretics, which non-sparing basically. Iron preparations, as we all know. Then you have your polysaccharide sodium sulfonate. Antacids also cause constipation. Muscle blockers or ondansetron are again very constipating agents. So to give an example, let's say there is a 68-year-old male with gastric cancer, and he was admitted for pain crisis, and he's been on these many medications for now, and he kind of improved on that. I mean, he was given injectable morphine through a patient controlled analgesia system, and requirement was around 70 mg. But he feels constipated since 3 days. So last bowel movement was 3 days ago. What do you feel is the reason for this constipation now? Anyone?
Ma'am, you're muted, ma'am.
Sorry. Can you hear me now?
Yes, ma'am.
Okay. So the reason for constipation would be the increased dose of morphine currently. So basically that would be the uh, opioid induced constipation basically. Now again, the same patient 6 months later, suspected ileus, opioid medication and bowel regime titrated as an outpatient. Constipation has been an issue since the beginning of the therapy with opioids. Now what would be the, and this is the current bowel regime medications that are going on. So he's on Docused, he's on Senna, he's on polyethylene glycol and Bisagol suppository as and when needed. Do you feel he needs something else? Do you feel peripheral antagonist would help here? How would you manage the constipation here? Because you're giving almost everything. You're giving bulk forming, you're giving motility agents. Opioid sparing drug would be one way to go, but if it's too painful and he is in need for, let's say, morphine, anything else, you have to give opioids. Anything else that can be done? Can you make, since Pamoras are not available with us, so that's the reason why. Because if methyl naltrexone was available, then it would have been very easy. You give that along with morphine, peripheral effects won't occur only. So he will be pain free and symptoms free, like side effects free. But let's say as it is not available, anything else that can be done to overcome this? Will opioid rotation help? Is that an acceptable? I mean, if the constipation is too worrisome or too troublesome, will switching over to an opioid which is less constipating, for example, fentanyl or buprenorphine, would that help him? If it's available, then we would want to go for Pamoras. If it's not available, then switching over to a less constipating opioid, which is either even methadone is less constipating compared to morphine. So either fentanyl, buprenorphine, or methadone if it's available. Okay. Another case, a 57-year-old female with stage 4 ovarian cancer. Now she has been having this continuous colicky abdominal pain with abdominal distension and has not passed passed stools since 7 days. There is associated nausea and vomiting. The vomitus is acute, large volume, and contains undigested food. and there is absolute relief after the vomiting episode. What do you feel? Is this patient constipated or is there anything else? Obstruction. Correct. So this is typically typical presentation of an upper GI obstruction. Okay, now coming to malignant bowel obstruction. So basically, it is because of ineffective motility or occlusion of the lumen. Okay. So mainly occurs in abdominal or pelvic malignancies, but sometimes might also occur because of metastatic to peritoneum, because of lung, breast, or esophageal malignancies as well. Now, large bowel or small bowel obstruction, there can be partial or complete obstruction. Now, if you look at the overall survival or the median survival in these patients, so if the obstruction is operable, that is, it's just one level obstruction which can be operated, then the prognosis goes up to 4 to 6 months. If it is inoperable with multiple levels of obstruction, it comes down to 4 to 6 weeks. Now again, the same patient, a 57-year-old female with stage 4 ovarian cancers, continuous colic abdominal pain with distension, no bowel movements in 7 days, associated with nausea, vomiting, which was large volume containing undigested particle with relief after emesis. So we said that this is obstruction, most probably an upper GI obstruction based on the symptoms. Now coming to how it occurs. So I'm sorry about the lines. So if it's partial or complete obstruction, what happens is that there is interruption of the passage of stools through the bowel. Right. So what happens in effect is that your luminal contents would increase. Correct. So because of this, what happens? Bowel is distending. Because it is distending, the surface area also increases in effect. Okay. Now, because of this, what happens is, as the surface area is increasing, the bowel secretions are also getting increased in terms of fluids like water, sodium, and chlorine. Just can you give me 1 minute? I'm just getting a call. Just 2 minutes. So we were getting to that because of the increased surface area, what is happening is that the bowel secretions are also increasing, which in effect would again increase the bowel distension, right? Now, because all these contents are getting accumulated in your gut with no way to pass it out, what happens is that the pressure increases and you feel nauseous and you might vomit as well. Now, because of the distension and increasing luminant content, what happens is your peristaltic movement also increase. So there is bowel contractions, which would lead to pain, your colicky abdominal pain, right? Now, because of the distension again, there is also a dull continuous ache. So there is a colicky pain and there is continuous abdominal pain. Because of the distension, there is damage to your epithelium as well, which causes a sort of a hypertensive luminal state. So, because which again increases your colic, but also gives rise to an inflammatory process in the lumen, which leads to production of prostaglandins, your secretagogues, and nociceptor mediators, which would again cause a lot of pain. This also leads to hyperemia or edema of the intestinal wall, which will again lead to your increasing in secretions into the gut lumen. Then, so basically, as you can see, this causes a vicious cycle. One is leading to another, coming back to the first thing. So this is a vicious cycle which leads to increasing pain, nausea, vomiting, and increasing in symptoms. Now, if it is reversible, it has good prognosis. If even with non-surgical measures or with surgical measures. Okay. And as we discussed earlier, it can be partial or it can be complete. Now, if you're managing a bowel obstruction, the simple thing would be that you put in an NG tube temporarily with an antiemetic, most probably haloperidol, because it does not have a further constipating reaction. And prognosis would be if you have surgery, then it can extend up to, or rather, if it's curative, it can extend up to years. If it is more of supportive measures or palliative, then it can be in months. And if it's inoperable with only supportive measures, it can be weeks. Interventions, so surgical management would be either stent insertion, or surgical interventions, like you remove and anastomose the ends. Decompressive interventions like putting in nasogastric tube, putting in and venting gastrostomy. Venting gastrostomy is basically feeding gastrostomy, but it is used to remove the bowel contents or the stomach contents rather than putting in or feeding through that. Okay. And coming back to the flowchart. So basically, if you want to go for management, so what you want to do is you want to remove or reduce the luminal contents. You want to reduce the contractions, the pain. So colicky pain and the abdominal pain you want to reduce. You want to reduce the nausea, and you want to reduce the inflammatory response. So basically, if you luminal contents can be removed via two things. So if it is partial, you can hope that it passes through that narrow opening that is there. So prokinetics would help here. If complete, luminal contents can be decreased by putting in a NG tube with aspiration. So continuous aspiration can help. Then anti-secretories would help with decreasing the secretions into the lumen and also decrease the edema. Then antiemetics would help with the nausea, vomiting. Steroids would help with the inflammatory process, and analgesics would help for the colic and the abdominal pain. So these are the major areas where you want to focus on to manage a bowel obstruction. So if it is partial, so what you want to do is that you want to get the gut to start moving on its own, so that it sort of helps, or it starts kind of working on its own and gets the bowel moving. Okay. So here you won't need much of anti-secretories because it's already passing thoda bahut. So anti-secretories would not be necessary here. Laxatives on the other hand would help a lot. Prokinetics plus minus. If there is a lot of colic, then giving prokinetic would further aggravate the colicky pain. So prokinetic can or cannot be given. Steroids would help again to lessen out the edema in the gut lumen itself. Plus, if there is an tumor which is causing pressure, it helps take away some of that pressure as well. Anti-nausea measures or antiemetics would help a long way, and reducing the opioids or switching over to some other analgesics for the time being till the MBO has opened up. If it is complete, on the other hand, you want the goals become different. You want to shut the gut down completely. So you basically want to give your gut a rest. So you would use the steroids here very liberally. It takes away the edema. It will help with the secretions as well. You will use opioids because there will be a lot of pain associated with complete bowel obstruction. So, and opioids will again help you reduce the peristalsis or the colicky movements also, because as we saw that it reduces the peristaltic movements of the gut. So opioids would help with both. Anti-secretory agents would help reduce the active secretions that are going on. So it reduces the bowel content, which will again help reduce the overall symptoms. Antiemetics, haloperidol, or here ondansetron will also be useful. Venting gastrostomy or NG tube in place. Now explaining it with an example, it's a 42-year-old female with cervical cancer. She has peritoneal carcinomatosis, admitted with small bowel obstruction. Currently, the medication is metoclopramide 10 mg Q6 hourly, dexamethasone 4 mg BD, haloperidol 0.5 mg Q6 hourly plus PRN as and when needed, and octreotide 0.2 mg IV TDS. Is this correct regime, or you feel that it should be something different? Is this correct? Basically, I feel the history is not complete. We don't know if it's a partial or a complete bowel obstruction. But let's see. Okay. So pain, for continuous pain, you would give opioids. For colicky pain, you would give anticholinergics like scopolamine or hyoscine or glycopyrrolate. Anti-secretory would be octreotide. So here octreotide was given as an anti-secretory. RT aspiration would help, yes. For nausea, metoclopramide can be used only if it is a partial bowel obstruction because it is a prokinetic. So it can aggravate the severe colicky pain if it is present. Octreotide would also help with the nausea vomiting, as in because it reduces the secretion, so the luminal content automatically decrease. So it helps with nausea in that sense. Scopolamine again helps with the secretions and with the colicky pain. Haloperidol is an antiemetic. Now, common dosage, basically dexamethasone can be given in the dose of 6 to 16 milligrams IV daily, can go up to 24 as well. Glycopyrrolate can be, we don't use glycopyrrolate as such, we would use more of hyoscine, which is technically 10 mg Q 6 hourly to 8 hourly, depending on how bad the colic is. Octreotide can be given as a continuous infusion or can be given Q8 hourly at the dose of 0.2 to 0.9 milligrams per day. And metoclopramide, if there is no colic and if it is partial obstruction, at the dose of 10 to 20 mg Q6 hourly. Thank you. So have you understood the management? It can be a bit confusing, but have you understood it completely why we are using metoclopramide in partial and haloperidol in complete? Is that clear?
Thank you, Rutula. Like, I think Rutula's question is quite important because you also have, like, as she has shown so many cases. For example, I can add on a little bit more to make, like, if the patient is like terminally ill, but still has small bowel obstruction. So those are the conditions where you have to weigh the balance and see. So is the point clear where you use metoclopramide and where you should not use metoclopramide? Anyone can unmute and ask, or someone has asked, please elaborate. Let me read the chat. Please elaborate it again, madam. You're muted, Ritula.
Yeah. Okay. So complete bowel obstruction and partial bowel obstruction. Okay. So the basic difference is that partial bowel obstruction, at least some sort of bowel functioning are going on. It's not completely blocked. Okay. So some part of the stools can pass through that, whatever opening is there. So what you want to do is you want to help the gut to start functioning on its own to pass the stools or pass your bowel motions as fairly as you can. So to do that, what you need is you can use a prokinetic, you can use steroids to reduce the edema, and you can use laxative because it's passing, but it's not passing at an optimal pace, right? So that would be partial obstruction. Now, on the other hand, if it is a complete obstruction in the sense that he or she has not passed like he's not passed stools for complete, no, nothing he or she has passed for a couple of days. There is a lot of nausea, not a lot of vomiting. There's a lot of colicky pain. So usually these are the signs of complete bowel obstruction. There can be spurious diarrhea. Spurious diarrhea is where it is actually complete obstruction, but because there is a lot of fluid that is getting accumulated in that part of the gut, some of it overflows. And it is foul smelling and may or may not contain small bits of stools. Okay. So complete obstruction would be that he or she has not passed stools at all. Flatus also sometimes might not be passed. So it's obstipation, basically. Obstipation is usually a sign of complete bowel obstruction. So when it's complete bowel obstruction, what you want to do is you want to stop the gut move. Because if you further try to increase its work, pain will increase, colic will increase, the nausea would increase. So you want to give it a rest. So if you want to give it a rest, what do you want to do? You want to give opioids here, because the opioids will again help you to stop that peristalsis and slow down the gut. So opioids would help with the continuous pain that is there. Plus it would help with your uh, colic. Then you want to give antiemetics because there's a lot of nausea involved. So what are the options? Something that is centrally acting again. So ondansetron or haloperidol, right? Then steroids would be given because you want to reduce the luminal edema and inflammatory process that is going on. So dexamethasone. Then anti-secretory agents, because as I said earlier, because of the stretching of the epithelium of the lumen, it and because of the inflammatory process that is going on, there's a lot of secretions that are coming into the gut, which has no way to pass. So that will again increase the luminal content, again increase the edema, and again increase everything. So you want to reduce that secretion. So anti-secretory agents, which is most commonly used, is octreotide. So you give octreotide as an anti-secretory agent, which will help bring down the secretions. You're putting in an NG tube anyway. So any stomach content would be taken out via the aspiration via NG tube. But again, wo hota hai na, like you've not stopped the secretions from entering again. So you want to give something to stop those secretions, so anti-secretory agents. And so that is how the regime is. Anything else that usually an X-ray will also tell you if there is an obstruction. Now, complete and partial, it can be taken out through history also. But if you want to confirm, then a CT scan would be preferable. Passing of flatus can or cannot be there. If it's somewhere above, the flatus can be passed because of the working of the lower down lumens, like gut. So flatus plus or minus. Complete obstruction, generally there is no flatus, but sometimes it can be.
Thank you, Rutula. Just like it all depends on the disease condition of the patient and goals of care. Okay, if patient is in a condition where patient is for complete management, you do further investigation, CT scan, then NG tube, then further if surgical option of relieving the obstruction or whatever has to be done. So when do we involve GI surgeon for so that is where I was coming to. Just one second, I'll just read. When do we involve the GI surgeon for complete obstruction? Okay, so basically it depends on, like as I said, no, the diagnosis. See, the patient, you would have known if the patient has a is in the initial phase, that is for all corrective management, then that's why I said goals of care. Okay, so there you make a call based on that. So if the patient is for everything, then you do a CT scan. Then once the CT scan is done, you get a surgical opinion whether it is a correctable cause, surgical correction, or if it is going to be a colostomy correction, whatever it is, no, that decision is made by the surgeon. So in that case, if it is complete obstruction, it goes in that way. I will just go ahead, Ritula, and then you can add on on top of it. So if not, so that is one option. The same, you can take the same patient itself, but the goals of care is different. He has some large bowel disease, and it is an advanced stage of the disease. So goals of care is palliative care management there, and then you make a call. So in that case, like I will tell about, it could be if there is a mass, then grade stage 3, stage 4, it could be a partial or a complete. Okay, so there, when the goals of care is only palliative management, and you are suspecting partial obstruction, there you give metoclopramide just for 1 dose, 2 dose. Observe. 1 dose, oh, there is some benefit, you can continue on. 1 dose you give, no, colicky pain. So stop, review again, and then look at other ways of management. So symptom. So that is why goals of care is very important there. And even based on the goals of care, I'm not stopping doing anything. So if you suspected partial, so you tried metoclopramide, so you didn't give. So then you go on managing like a complete obstruction. NG tube, then seeing what secretion. See, one of the good things which I was attracted with today's presentation was she gave you the vicious cycle, which is the cause. And then in that itself, she had the pharmacological management. So you can stop the vicious circle in any point, or try to avoid the vicious circle going back again and again, causing more discomfort. So either reducing the secretions, or based on what? Reducing edema, everything matters and everything helps. So based on the goals of care, you tailor make the management. Rutula, you go ahead and add on whatever you want to, and then we will ask whether we have answered all their questions and queries.
So basically, as ma'am said, like it depends on the pathology also when you want to include the GI surgeon. But generally, it is if it's a one level obstruction, if it's just obstruction in only one place, then it's okay to operate. If it's like a multiple level, then how much are you going to, and where all colostomy are you going to do? So it also depends on that. And yeah, so and again, it depends on the goals of care, as ma'am said. And sometimes the colostomy can be more distressing than the constipation or the pain. So it again depends on the patient's wishes and preferences as well. So we'll have to manage it accordingly. And
there's one more question in the chat box, Rutula.
These patients to be managed as in patient of home care. They can be managed at home. I mean, if the symptoms can be fairly controlled, and if they have the if they're actually empowered to manage it at home, it can be very well managed at home. It does not have to be only in the hospital or in an hospice. They can be very well managed at home. They might require support for the initial few days, but after once it starts passing and they start tolerating oral feeds, then we can switch over to oral medications as well.
Exactly. Now, only thing again, no, when you think of home management, no, their awareness, and then some nurse at least going and seeing them. See, it can be managed at home, nothing, no one sees, and everything remote means patient and family may become a bit apprehensive. See, for example, this vomiting, nausea, constipation, and all may seem very simple, but it will be very bothering to the patient. Okay, and for example, constipation, no, we see many patients, and it is something which is really, because many may be in the habit of opening their bowels once a day or twice a day, or at least once. If that doesn't happen, it causes a lot of distress both to the patient and person and the family. So these things have to be managed appropriately. So if you're thinking of managing it at home, raising awareness and doing some caregiver awareness, and also making sure someone at least goes and sees the patient, like some form of home visit to be done at least by the nursing team. so that the nurse can go see, and if they have any queries, they can call the doctor from the patient's house. So you can, so the physician can, in today's thing, no, can have a video call, see what are the distress and problems, and then, so that is another thing. It all depends on, if you are not that, it cannot be managed. If it is managed, it has to be having these type of options also available. So, and then again, each step by step, as I said, whatever is the symptom of concern, correct that symptom as much as possible. I think that was the, I think those were the message in the chat. Anything else anybody wants to ask? You can either ask directly or there is no case presentation, Rutula, because there were only cases for nausea, vomiting. They did not have any case for thing. Glad that you brought up many cases in the presentation itself, because these are quite common, and especially, you know, at this point, like you have had also when, like when we were doing the pain relief opioid session, when you write a prescription for morphine, the prescription is incomplete if you don't include a laxative in it.
Yeah.
Okay, so that is something very, very important, because again, in that respect, I would say you write, because see, there may be someone who has diarrhea as their normal symptom. Okay, there are many, like, see, the benefit and risk of medicine is, it's not, everyone is unique. That's the charm of the medicine itself. So if you are going to get a patient who has diarrhea as their regular symptom, so even then you write the laxative, Bisacodil, and then tell them maybe they titrate it according to their their individual habits. Okay, so the morphine prescription is incomplete without a laxative, because this is such a common side effect, and that should never be missed. So that is something I just wanted to reiterate, because see, even in the first thing, no, like I think the first case what Rutula brought up, the problem was with the morphine. So if morphine is bound to cause that, and we have to see, again, just because of that, they should not stop. We have, I think one of the days we had a case presentation, the patient and family were not happy to give morphine because it causes constipation. I think like 2 sessions before we had a case in which it was. They were not giving the pain relief. So pain relief was not given importance. Their constipation was given importance. So this is all, as I said, no, that is some symptom which is bothering. And what is bothering for X may not be bothering for Y, not for Z. So these are things individual. So these things have to be given importance and then managed accordingly based on the need and individual patient. Okay, anybody else wants to add on anything? Rutula, you want to add on anything, or is that?
No,
No.
done.
Okay, then. No worries. In that case, a big one thing, some messages there.
Is there
Is there any structured skill?
a
I didn't. Can Dr. Premnath say what is what he's looking for?
training, structured skill training for palliative caregiver? We are doing a structured training program. This would be a part of the training program. Do you mean hands-on training? Then maybe you can go to will there be like
No, exactly. See, today in the first 10 minutes, I did that only to them. See, I don't know, some ESP is there. So what he asked only was I was trying to tell them. In the first few minutes when you were waiting to join, that hands-on training is so important. See, when you do hands-on training, no, so all the nurses are trained to give various types of enema. Normal, like suppository, normal enema, high up enema, the gadgets and the tools, everything. No, so I was mentioning it is important that this online session will not be complete without hands-on. So I was mentioning to them about 5 days or 10 days. Is that what Dr. Premnath you're trying to ask? Because is that what type of structure training? This it's a what you are all going through. No? This 20 session program covers the knowledge, information, and then knowledge and some skill. As I said, no, communication is one of the skills. Then you have the hands-on also to do, so that you see patients and you will see, like for example, pain relief also. We do give case scenarios, what patients we see and things like that. But beyond that, no, you have to see to believe. See, for example, there are many more we can go on telling. Very young patients we do have a lot, whom we will see, and then who are able to, when they get their symptom management sorted, they go ahead and lead a normal life, what they can. See, the normal could be a new normal, or whatever is the normal possible for them at that point of time. So all that will be possible only when you actually see patients, either as inpatient in palliative care services or in home care services. So that is what I was trying to tell them about Pallium, in which you get to see both. Or nowadays, many centers are doing inpatient and home care, but the number of home care visits and things vary from place to place depending on the resource availability. So that is what I was telling to Dr. Premnath. If you could unmute and ask if skills of passing. Yes, I think that one. No, you will have to exactly. I'm answering the same thing. You will have to be there to do these things. Rice tube and all can be done very well. You can ask the patient to give small quantity of water, ask them to swallow, and then you do the rice tube. So that our Pallium Indian nurses are trained very well. All these are done by nurses at home in the home visit. Yes, in rice tube, urinary catheter, like PRE, like rectal examination, high up enema, bowel evacuation, everything is done by the nurses in Pallium in the home. So yes, they are all, everyone, people are trained, and as I say, no, these are done at home. Regular urinary catheter changing is changed. Rice tube also is mostly done by them. If they have difficulty, they will ask and we will go. But mostly, no, again, there also, if it is a head and neck CA, their being brave and attempting is not the right way forward. So again, everything depends on the individual case. But there are training for all these. There is something, less palliative care, training for team members other than doctors. Yes, that is what, that similar training, Dr. Pushpa. The answer for your query is, similarly, there is a nurse FCPM, nurse training program is there, 18 session program. And for that also, there you can have hands-on training for them also. And there is a 6 weeks in-house training program for nurses and doctors, which can be done in Pallium itself, staying in Pallium for 6 weeks, which will include everything, hands-on, home visit, inpatient, outpatient, everything. That is for Dr. Pushpa. And the next is, does palliative care in GIT include Ayurvedic procedures like Bhakti? That
Um,
you go ahead.
So again, if it's an obstruction, then doing something like Basti would aggravate the situation. So you'll have to be very careful when giving it. I don't think there is anything which says that you cannot do it. But if it's a complete obstruction or bowel obstruction, then it's better to avoid it. If it's for constipation, you can try it. But again, it depends on how much it's benefiting versus how much it's affecting the patient. So you'll have to go according to that.
Exactly. See, the other modes of management, no? Not that we say no to it. We are not experts in it. Okay. So some experts have to be approached, and then you have to know the interaction. As Rutula mentioned, no, if it is going to be opposite, so then, as I said, no, I am not an expert in it. Someone should be an expert. So there, when we are not experts, we don't have the right to advise. So that is one thing. And for BLS, ACLS, no,
Okay.
palliative caregiver train, I don't think, I am not aware. Rutula, can you update on that?
That is like a primary, like MBBS level, people also do BLS, ACLS. So it depends on institute to institute. Like some of the institutes have it a mandatory thing that BLS to aana chahiye sabko. So if that's a compulsory thing, then get it. And it's not something which is going against your principles or anything. It is a basic training for any doctor as such. So I have no problem. I mean, I don't think that it should be or should not be. It's not mandatory thing.
The only thing is that wherever it is available for training, it is another skill worth
Yeah.
obtaining.
For training,
See,
yes.
it is a skill worth obtaining, and again, some institutions have compulsory, mandatory requisite. You have to have it. So BLS is something everyone, any medical professional is worth having it. And ACLS, I would say, any doctor also, practicing physicians, better to have these things. It is your own, these
Interest.
like, no, these are all ethics and things which will be worth having it. And I didn't catch, is palliative caregiver trained in BLS? So that's what this is like. It's not that question. It's about training is an additional qualification which can be obtained. Whether
You want to do it or not, that's up to you. But it's
exactly. So I think that is what, and it can, and there'll be organizations who may be conducting training for these.
Nowadays, non-medicals are also getting this training.
Mm.
Like in
Yeah.
Jeev Raksha, they train all people like for a BLS.
Exactly.
BLS, they are getting, and it's actually a good skill set to have. Like in case of emergencies, then I mean, you can something till the ambulance comes in. So
Exactly. BLS is something very helpful for the community.
yeah.
Because see,
Especially
for
if there are
example,
volunteers.
Yes.
Especially if there are volunteers.
correct, volunteers, and then in some common situations in shopping centers or something like that, and all, it is benefit for the person who suffers the incidents, then that will be helpful. Okay, then I will hand over it to Sangeet. A big thank you, Ritula, and a big thank you to all of you too.
Thank you, Rutula ma'am, for the wonderful session. And thank you, Radha ma'am, for facilitating the session very well. Thank you all for participating, actively participating in the sessions. Thank you. Let's see you in the next session. Bye.
Bye-bye.
Thank you.